Morning, everyone. I'm Dr. Laura Lacher, and welcome to today's very special medical grand rounds. Per usual, we'll go ahead and get started with some reminders and logistics, and then introductions for today. Please be sure to join us next week. We will be hearing a talk about care for patients who are houseless, given by Drs. Michelle Beam and Meg DeVoe from OHSU. As many of you know, Grand Rounds is now a joint collaboration between Providence St. Vincent and Providence Portland Medical Centers. Welcome to those of you joining us on Teams Live. I am here at Souther Auditorium at Providence St. Vincent. Grand Rounds is typically live here in the room at St. Vincent on Tuesday mornings at 8 a.m. And sometimes we are also live at Providence Portland on Tuesdays at noon. You can always earn CME credit by being here live in the room, by watching on Teams Live, or by watching a recording of the event. If you look at each week's Grand Rounds invite, you can get information about the recording and verification of where and when we'll be meeting. I'll be monitoring the Q&A throughout today's session, so for those of you online, please go ahead and post any comments or any questions, and I'll mostly hold those until the end as time permits. And now to introduce our annual Richie Wernick Memorial Lectureship in Medical Education. Many of you know that Dr. Wernick joined Providence Portland Medical Center in 1981, where he remained on staff for a remarkable 37 years. A tremendous friend and mentor to me and so many others, Dr. Wernick educated and mentored countless medical students, residents, and faculty. In addition to direct teaching, he was a pioneer, a leader, and a visionary in continuing medical education, helping to bring the highest quality of education and professional development. He was humble to a fault and yet recognized often with teaching and clinical awards, including the Oregon ACP Distinguished Teaching Award. Always generous with his time, Dr. Wernick was a truly elite teacher of evidence-based medicine. Richie's love for medical education was only rivaled by his love for music, dogs, and baseball. Go Mets. And it is to honor him that I am delighted to introduce today's speaker, Dr. Benjamin Wang. He too is a practicing rheumatologist at the Mayo Clinic, Florida, and assistant professor for Mayo School of Medicine and Science. His academic interests include inflammatory arthritis, sarcoidosis, autoinflammatory diseases, and fibromyalgia. Dr. Wang earned his medical degree at the University of Toronto in Canada, where he also remained for residency in internal medicine and clinical fellowship in rheumatology. He then went on to complete additional research fellowship in the Division of Immunology and Rheumatology at Stanford University. Dr. Wang has won multiple awards for teaching throughout his career. He is the co-director of Mayo Clinic's Rheumatology for Primary Care Conference and also associate program director of the Rheumatology Fellowship at Mayo Clinic in Florida. He is still a believer in the bedside physical exam and will never miss an opportunity to help enhance the skills of a willing learner. Sounds like another teacher I know. Dr. Wang enjoys the sport of cycling. When not repairing his bike, he has been found tinkering with a team of engineers at Mayo Clinic to develop next generation practical technologies for use in rheumatology practice. Dr. Wang, what an apt tribute to Dr. Wernick. Thank you so much for joining us today.
Thank you very much, Laura. It's a real pleasure and an honor to be here to give the Richie Wernick Memorial Lecture this year. I was able to learn a little bit about Dr. Wernick over dinner last night, and I must say that his story is truly inspirational. In Mayo Clinic parlance, he is for sure a three shields kind of guy, and someone that we would aspire to emulate. So thank you all for attending, and thank you for all who are attending virtually. I hope that this time would be an apt tribute to Dr. Wernick and would inspire us all in our pursuit of medicine. This morning, what I'd like to do is present a topic that is maybe a little bit esoteric, but will illustrate how far we have come in the understanding of inflammatory diseases. I have people ask me all the time, what is rheumatology and what is a rheumatologist? It is for sure the least informative title of any specialty in medicine. So I had to look it up. I had to actually go to ChatGPT to find out what is the rheum in rheumatology. And you know what I got? Phlegm. Uh, so, so that doesn't really help. But if I were to say in broad strokes what a rheumatologist is, maybe I would describe a rheumatologist as an inflammologist. A lot of our practice and a lot of our research is in the field of inflammation. And so I'd like to present something regarding inflammation, something next steps as far as what we understand, and something really apart from traditional autoimmune diseases that we are associating with my specialty. The autoinflammatory diseases are actually a group of fairly newly described disorders, at least from the pathogenic standpoint. It wasn't really until 1997 that the first molecular understanding of unprovoked inflammation came to the fore, and this was through Dr. Daniel Kastner's lab at the NIH. He was the one who discovered the single gene mutation that was responsible for the syndrome known as familial Mediterranean fever. And this understanding catalyzed the development of understanding in a whole realm of diseases. This is a diverse set of conditions that that has myriad inflammatory manifestations as their hallmark. And this might include periodic fever, but also inflammatory manifestations involving the skin, the joints, serosal membranes. We see vasculitis sometimes, we see lymphadenopathy. And so a general inflammatory picture is how these clinically present. The early known syndromes have been described to be associated with single gene mutations, and I'll walk you through several of them as illustrations. But as the field has evolved, we have now appreciated that diverse mechanisms are involved. And the commonality among all of them is that they involve dysregulation of the innate immune system. The innate immune system, you might consider it as the primitive part of our immune system, the very basic part of our immune system that ends up generating inflammation. It's fairly nonspecific. It doesn't involve autoantibodies. It doesn't involve T cells and B cells specifically recognizing antigen. It's just there as a general protective mechanism, but this mechanism can be disordered to give you these family of diseases. And many of the febrile inflammatory syndromes are still without genetic definition. But I must say that if you peruse the literature, you'll find new discoveries being published probably every month. Now, the fever of unknown origin, this and the next slide are some really old illustrations from up to date. And this information actually comes from a former mentor of mine, Alan Detsky, at the University of Toronto. And this is a kind of a decade by decade survey and understanding of what is the source of a fever of unknown origin. And we can see that, you know, as far as infections are concerned, in the 1950s, a lot of FUO was thought to be of infectious etiology. But as the chart shows, decade after decade, people were discovering maybe not so much infection. Likewise, malignancy, you know, the very esoteric fevers that come with cancer syndromes and paraneoplastic syndromes, maybe at one time were thought to be relatively prevalent, but over time have kind of dropped off. The inflammatory conditions seem to kind of at least hold their own as a diagnostic possibility. And as you can see in the far right panel, the no diagnosis, or we really don't know where this is coming from, has really admittedly become pretty common. There are a lot of causes or purported causes of fever that might have an unknown origin, and this is not for any kind of memorization, but just illustration, that anything from rare or sequestered infections like a discitis or a vitritis or prostatitis could be the source of an unknown fever, malignancies, the systemic diseases that I deal with day in, day out, including the multi-system autoimmune diseases. Truthfully, they're not really frequently a cause of an unknown fever. And then we have a lot of miscellaneous diseases. So these are all, at least in my mind, swimming around all the time. And unfortunately, it doesn't often result in a clear diagnosis. Of course, we need to understand population uh, uh, epidemiology, and we have to really admit that really the most common cause of an unknown fever might be, well, especially in the tweens to early, years, maybe conditions like this, or for those of us of a more mature vintage, we're still staying alive. At this point, I want to make the distinction between what is autoinflammation and autoimmunity. Autoimmunity, of course, is a very refined response of the immune system. It involves the immune system's ability to recognize precise antigens and mount a very directed response, both humoral and cellular, toward it. Systemic lupus is a prototype of an autoimmune disease in which there is abundant antibody production. So lupus is characterized by a lot of autoantibodies, indicating that the immune system is really targeted, it's very knowledgeable about what it's going after. Unfortunately, these antigens are self-antigens. Rheumatoid arthritis is another example of a very focused, very honed immune response. All of the immunological characteristics of rheumatoid arthritis speaks to this. There's a very restricted use of the genes and T cells, which means it's very precise. There is immunoglobulin class switching going on from more general epitopes to highly specific IgG molecules. Antigen presentation to T cells is limited to certain genes. These are all testament to the fact that the immune system is very, very directed. However, autoinflammatory diseases apparently are unprovoked. They're unprovoked by antigen, either internal or external. They're unprovoked by infection. They just seem to happen. They just seem to turn on. And here's where the research has really given us some light regarding mechanisms. So just to review, the innate immune response is very, very basic. We have perhaps a pathogen that enters the body, and it is somehow, and there are general recognition mechanisms that cells like macrophages could recognize these pathogens and then phagocytize and eliminate the pathogen. Or in a slightly more sophisticated sense, the pathogen could be recognized, internalized, and then this cell could send a cytokine signal that activates one other generation of cell, in this case a neutrophil, which then will have some response in phagocytizing the pathogen. So this is basically the innate immune response. In contrast, adaptive immunity occurs when the antigen or pathogen is recognized by a so-called antigen-presenting cell, in this case a dendritic cell. It could be a macrophage or other, which is then internalized by this cell, processed internally. The cell then migrates to an immunologically rich area like a lymph node and actually displays parts of the antigen on its surface to other cells in the immune system, like a T cell. And so this process, known as antigen presentation, primes and activates T cells, which then serves as a quarterback to mature the rest of the immune response. And so downstream, we have the production of specific antibodies, we have the activation of specific immune responses. So this is adaptive immunity. Autoinflammation is the dysregulation of innate immunity. And so those components that are not involved in adaptive immunity are active here. The cellular components might include macrophages, dendritic cells, neutrophils, and natural killer cells. And cytokines are very prominently involved, including IL-1, TNF, etc. I'll talk about something known as the inflammasome, and this is an assembly of proteins in the cytoplasm of the cell, which then is responsible for activating cytokines. In addition, nuclear upregulation of inflammatory genes through mediators like NF-kappa B are involved. So we're going to wade into a little bit of deep water here and talk about mechanisms. And this is actually an important slide because it illustrates not only the mechanism behind autoinflammatory diseases, but inflammation in general. Of course, we recognize the cardinal symptoms of inflammation: redness, swelling, pain, loss of function, etc. But this is actually the real underpinnings of why this happens. Pathogens display on their cell surface molecular patterns and motifs, which scientists have called pathogen-associated molecular patterns, or PAMPs. There are some intrinsic molecular patterns known as danger-associated molecular patterns, or DAMPs. These are generally recognized by a fairly primitive signaling system known as the toll-like receptor on cell surfaces. Toll-like receptors are expressed on macrophages and other cells. Upon recognizing these PAMPs and DAMPs, toll-like receptors will signal the cell in three distinct ways. First of all, and not all the steps are illustrated here, through NF-kappa B, it turns on nuclear transcription of genes that produce pro-inflammatory molecules, chief of which include interleukin-1 beta and interleukin-18. Secondly, the toll-like receptor will also signal activation of a certain series of cytoplasmic proteins known as the inflammasome. Thirdly, these will actually translocate into the cytoplasm and transport the PAMPs and DAMPs to the inflammasome, further activating this system. The inflammasome will then assemble together. This component is actually going to get together with 6 of its neighbors and produce this wagon wheel looking structure, which has a very potent enzymatic activity, which is able to cleave the proforms of IL-1 beta and IL-18 into their active forms. So the inflammasome ends up being an enzyme which catalyzes conversion of inactive forms of inflammatory cytokines into their active forms. These active forms, as we know, can act downstream in the cellular system to really produce inflammation. They also feed back positively on the cell to perpetuate this entire cycle. So central to inflammation is actually activation of this inflammasome interleukin system. The inflammasome, it turns out, is central not only in certain genetic diseases of autoinflammation involving that protein specifically, but very generally, it turns out, in many of the autoinflammatory diseases. Interestingly, the inflammasome is also activated in gout, which is a very richly inflammatory condition, and also might be responsible for the inflammation at baseline that we see in diabetes mellitus, in that hyperglycemia is now known to be a danger-associated molecular pattern that can activate this system. And so therefore, the inflammatory half or pathogenesis of diabetes may also involve this system. The inflammasome structure actually has 3 components. There is a platform protein component, so you can select one of these, join it to an adapter protein component, and then link that to an effector protein component. The effector protein component contains the enzyme caspase. This is what mediates the conversion of the proforms of the interleukins to their active form. And the various inflammasomes recognize various antigens in a very nonspecific way. We'll focus on this one called NLRP3, in which microbial pathogen-associated molecular patterns or endogenous danger-associated molecular patterns or crystals like uric acid or UVB radiation can actually cause ion fluxes that activate the inflammasome. There are other inflammasomes containing other components that might recognize various microbes um, across the board and also become activated. So recognition of these molecular patterns by both toll-like receptor and the inflammasome proteins themselves can activate this entire system, which then produces inflammation. Now I'd like to present a case of a condition like this. This is a young woman that I saw in my office, a 24-year-old at the time Caucasian female. Her racial and ethnic background was that her father was of Polish extraction, mother was of Serbian extraction. And since the age of 16, she had been troubled with recurrent fever and abdominal pain that occurred about every month to 6 weeks, and nobody could figure out why. She had abundant autoantibody testing. She was tested for a lot of different autoimmune diseases without a satisfactory answer. When you asked her about her fever pattern, and this is very important to do, she said that she would have 3 to 5 days of fever, pretty high, 102 degrees. Every episode would last about 12 hours, sometimes as short as 4 hours. And then after 5 days, it would go away. And she would be normal again for about 6 weeks, and then it would all recur. So this is very important because certain autoinflammatory diseases have certain timings, paces, and patterns. And it's very important to get that out of your history. She would temporarily get better with acetaminophen, various NSAIDs, and even prednisone. Her doctors even tried her on immunosuppressive medication with partial effect. She would have sharp, severe abdominal pain, pain with movement. She would have symptoms of a partial bowel obstruction, nauseated, constipated, and sometimes joint pain and muscle pain. Well, after reviewing her records and seeing that she had been tested for autoimmune disease about 6 times, all with negative results, I didn't think that it would be profitable to do that again. So I consulted with my genetics colleagues, and we actually did some genetic testing on this young woman. And her test came back showing that she did have one gene that was a mutation in the gene for familial Mediterranean fever, known as MEFV. Her mutation was not the most common one. The most common one is something called M694V, a single base pair substitution. She had another one that was a little bit atypical, but known to occur in about 3% of people with familial Mediterranean fever. And the fact that she was heterozygous didn't bother us either because this condition does not have a true classical Mendelian inheritance pattern, and heterozygotes may also be affected. Anyway, matching this genetic finding with her clinical presentation, we decided that this was probably a good case of familial Mediterranean fever. And we went ahead and treated her again with colchicine. Traditionally, treatment for familial Mediterranean fever does involve colchicine. She did have a partial response to it at the BID dosing in the past. She had also tried etanercept, azathioprine, with very partial unsatisfactory results. And even they tried an IL-1 monoclonal antibody known as rilonacept, again, with a partial response, but she got a rash from it, so she had to stop. So what we decided to do initially was just revisit colchicine and actually push the dose up to 3 times a day. Amazingly, she was able to tolerate it and actually did pretty well for a long time. She moved away from the area, so she was lost to follow-up, but I just talked to her family about 18 months ago, and she remained doing pretty well. Familial Mediterranean fever, as I mentioned, was the first genetically described autoinflammatory disease. And here's another representation of the inflammasome, the NLRP3 component with the ASE adapter protein, and then the caspase effector part, all assembled together. This inflammasome actually has a natural a natural inhibitory protein known as pyrin. And it turns out that there is a mutation in the pyrin molecule that kind of releases the brakes to this inflammasome protein. And this is what is responsible for familial Mediterranean fever. There's a single base pair mutation that disables the pyrin molecule and releases the activity of the inflammasome, causing unprovoked severe inflammation. So it was in 1997 that the genetic basis of this disease was described, and we know that it has an enriched prevalence in the Middle East, Mediterranean basin, but it is observed globally, and we do see patients from all over the world with various mutations in this gene. Periodic fever is a clinical hallmark, so is serositis. So look out for the patient that describes abdominal serosal symptoms, pleural symptoms, pericardial symptoms, in addition to other inflammatory manifestations such as synovitis, an erysipelas-like rash, cellulitis, something like we would see in gout. The onset is typically in childhood, late teens, most common, but FMF may have an adult onset, so don't rule it out if you see it in someone later in life. And as I described, mutations in the PYD domain of pyrin, the inhibitor of the inflammasome assembly, leads to decreased inhibition and therefore unprovoked and unchecked activity and inflammation. We do need to look out for secondary amyloidosis. This is particularly prevalent in certain racial groups with FMF, and this is something that we need to monitor through checking renal function, hepatic enzymes, and so forth. So the autoinflammatory diseases have evolved in our knowledge, and this is a schematic that represents some of the known single base mutations that involve various proteins in this inflammasome cascade. We described familial Mediterranean fever. There are other syndromes known as cryopyrin-associated syndrome, also involving a mutation in NLRP3 inflammasome. Other proteins like NOD2, which I'll describe a little bit later, have mutations that can also produce autoinflammation. So this is a partial representation of a growing spectrum and evolving landscape that I believe will become more and more known and more prevalent, even to the general internist in all of us. This is Dr. Kastner's own tabulation a decade and a half ago of his impression of the growing spectrum of autoinflammatory diseases, and he classified them by clinical syndrome. So the hereditary recurrent fevers, such as FMF, another one called TRAPS, involving the TNF receptor, and others. Febrile syndromes like juvenile inflammatory arthritis, adult onset Still's disease, and others. Still others, including SAPHO syndrome, gout, type 2 diabetes, are now all considered and classified among this family of autoinflammatory disorder. We still have unknown ones. We still don't know the genetics of adult onset Still's disease, Behçet's disease, very complex, still under investigation, and others such as HLH or macrophage activating syndromes, still under investigation. More recently, Ron Laxer, pediatric rheumatologist at the Hospital for Sick Children in Toronto, tabulated a molecular approach to classifying autoinflammatory syndromes. And this is just for us to appreciate how rapidly this field is evolving, how many gene mutations are now described, and these remain the single gene mutations. There are a growing list of polygenic conditions that are being understood. And this is an excellent review article on this subject. In fact, I'll leave you with a copy of these slides for your review. The mechanisms involved are not only mutations in the inflammasome, but we have protein misfolding, we have endoplasmic reticular problems, metabolic stress, disorders of autophagy, and differentiation problems in myeloid cells in a syndrome that you might have heard of, known as VEXAS syndrome, another one coming to the fore. Here's another case of a 60-year-old Caucasian female of Ashkenazi Jewish descent. She came to me having recurrent fevers for about 2 years to 101 degrees. The episodes would actually last an entire month, but without much ado would spontaneously resolve for about a month and then recur. During the inflammatory episodes, she would have joint swelling, abdominal pain, she would experience facial edema, and again, a very extensive serologic, infectious, malignancy investigation as to the cause was unfruitful. She started to acquire physical impairments and disability because of her joint symptoms. And again, she had partial responses to empiric therapy with methotrexate, azathioprine, even etanercept, after failing a number of NSAIDs. We sent her for genetic testing, and again, she came back with a pathogenic variant known as R121Q, a single base pair substitution, in the gene that encodes the receptor for tumor necrosis factor. And this variant is known to be associated with a condition known as tumor necrosis factor associated periodic fever syndrome, which is entirely unhelpful, so we just abbreviate it and call it TRAPS. TRAPS actually is a single base pair mutation in this receptor that is a gain of function mutation. And so this mutation causes the tumor necrosis factor receptor to signal into the cell constantly or frequently, and thereby turn on inflammatory mechanisms. It was actually first described in a family in Ireland in 1982, although the genetic mechanisms were not known at the time, and therefore it took on the moniker of Hibernian fever. Periodic fever, rash, arthritis, fairly nonspecific inflammatory symptoms are the clinical hallmarks. And here the pattern is sustained lower grade fevers lasting up to a month, then remit, and then to recur. So it's a little bit different from the FMF pattern, again, to illustrate how important getting a history regarding the fever pattern is, in addition to finding out the patient's ethnic and racial background. These are all very, very relevant. There are now over 70 mutations described in the TNF receptor gene, and they do cause increased activation through signaling or decreased shedding of the receptor. So some clinical keys in evaluating patients with these conditions are a detailed family history, including ethnicity, the age of onset. Know that familial Mediterranean fever and TRAPS can have adult onset, the periodicity and attack duration, like we've discussed, and the multiple inflammatory features. I wish that we had a little bit more specific way of delineating these diseases based on clinical features, but unfortunately, they're fairly nonspecific and sometimes not that helpful, although we know that serositis might be a distinguishing factor in FMF. Not common features are visceral vasculitis or hepatosplenomegaly. Definitely, we can see elevation of inflammatory markers like the ESR, CRP, and ferritin. If we actually measured cytokines, we would see elevations of IL-1, IL-6, and IL-18. And the usual workup for fever is usually unproductive. Again, some algorithms that have been published to try to help us delineate them. You can review these. I have found them, unfortunately, partially helpful. Again, we are looking for periodicity, intensity of the fever, and other associated conditions. In FMF, we can actually see cellulitis. So this is a gentleman with familial Mediterranean fever, not unlike many of the patients we see who come in with so-called cellulitis, but also with a fairly intense fever. And the cellulitis, of course, is unresponsive to antibiotics, and it comes back again and again. So after a while, you may have to consider one of these autoinflammatory syndromes in your differential diagnosis. An erysipelas-like rash is something very typical for something like adult onset Still's disease, but can be a feature of many other. This is a patient with TRAPS whose fever is lasting 10 days to 3 weeks in time. It can be maculopapular, evanescent, just like in adult onset Still's disease. Another inflammasome-mediated autoinflammatory syndrome known as cryopyrin-associated syndrome, or CAPS, is also characterized by breakouts of skin lesions that can be very broad in differential diagnosis. And of course, secondary amyloidosis is a hazard that we should all be aware of, mainly in the renal and hepatic systems. Its highest observation prevalence is in FMF, generally speaking, up to 15% incidence due to unchecked inflammation. There are no established screening protocols, but we frequently monitor hepatic enzymes and renal function very, very regularly. Now, in the clinic, genetic testing can be a little bit challenging, and in most settings, a geneticist is helpful. In most practices, if you do not have a clinical genomics department, then a call to pediatric genetics is often helpful. And very often they are willing to assist in the diagnosis and diagnostic workup of adult patients. We at Mayo Clinic do have a genetics department, and they are using 3 commercially available screening panels from companies like Invitae, Variantix, and GeneDx. These companies are very forward-thinking. They have expanding panels of genetic testing. Invitae right now is testing over 160 genes in their panel. Insurance coverage with the proper documentation is usual and possible, but out-of-pocket cost is about $2,500, so the patient should know that. But if you do come across mutations, and the geneticist will help you in the interpretation to say this is a known mutation, this makes sense with the patient's clinical presentation, then you can really move the case forward in a good way. The turnaround for such testing is about 6 weeks. Multiple treatment trials with biologic drugs have been tried. Really, what we are focusing on now is the use of IL-1 antagonists. There are 3 commercially available molecules. The primary one is canakinumab, and that's because it has multiple FDA-approved indications, including in adult onset Still's disease. Anakinra is another IL-1 antagonist, and so is rilonacept. IL-6 antagonists like tocilizumab can be used, but they are not FDA approved, and the rest of the molecules on this list are not FDA approved. Because these diseases do not involve inflammatory cellular mechanisms like the adaptive immune system diseases do, there's really a questionable role for acting on B cells and T cells with agents like rituximab or abatacept. So FDA-approved drugs for autoinflammatory conditions include canakinumab, which is an IL-1 beta antagonist. It actually binds the molecule itself. It's approved for FMF, for adult onset Still's disease, for TRAPS, and for cryopyrin-associated periodic fever syndrome. So there is coverage available with this molecule. Anakinra is an IL-1 receptor antagonist, so it binds the cellular receptor and therefore blocks the actions of both IL-1 alpha and beta. And it has 2 pediatric indications according to the FDA. Rilonacept is another binder of IL-1 beta, and it is approved in this pediatric syndrome known as DIRA. At this point, I'll walk you through three distinct syndromes just for illustration to review some of their clinical features and also to illustrate how far we've come in these conditions. The first one is familiar to all of us, adult onset Still's disease. And of course, it is a systemic inflammatory syndrome with a characteristic quotidian or daily fever pattern. So really what we're looking for is fever that occurs each and every day, pretty much the same time every day, and that would be late in the day or in the early evening. There is again this kind of salmon colored, we're in Oregon, right? So salmon colored rash. In addition to arthralgia, maybe even frank arthritis, pharyngitis, that occurs late in the evening associated with a fever, at which time the rash will become more intense. The laboratory hallmark is neutrophilia and extreme hyperferritinemia. So ferritin is an acute phase reactant. Its production is provoked by IL-1, and so ferritin levels even into the thousands are not that uncommon with adult onset Still's disease. The clinical phenotypes may include the systemic periodic inflammatory diseases and sometimes evolving into chronic articular disease. We still don't know the molecular genetic underpinnings, but it's a very complex pathogenesis. Again, a very good review article by Rossetti et al. That involves both the innate immune system with some, we think, spillover into the adaptive system, at least with T cell activation. Th1 and Th17 cells seem to be involved. A variety of cytokines, including IL-6, TNF, IL-1, and interferons, are involved. The treatment for adult onset Still's disease is still pretty empiric. We often resort to glucocorticoids initially. Second line, sometimes methotrexate or other immunosuppressive DMARDs are used. But really, because now there is an FDA-approved agent, oftentimes we resort to IL-1 inhibitors such as canakinumab. Of course, treatment is customized based on severity, comorbidities, and response. The second syndrome I'd like to illustrate is something called VEXAS. It's coming into medical terminology. My apologies that it is the most clunky acronym known in medicine. It's not like CREST syndrome, which kind of flows off the tongue and makes perfect sense. Vacuoles, E1 enzyme, X-linked, autoinflammatory, somatic. What? Anyway, this is a very interesting syndrome that actually involves both inflammatory and myelodysplastic features. It was discovered in 2020 and is characterized by somatic, meaning non-germline mutations in the UBA or ubiquitin-1 gene that is on the X chromosome. It tends to have a kind of recessive inheritance pattern, so overwhelmingly it involves males. The clinical features are interesting. For the rheumatologist, VEXAS comes to mind when we have patients, male patients, who present with a kind of a relapsing polychondritis picture. As we know, relapsing polychondritis often involves inflammation involving the pinna of the ear, maybe conjunctivitis, maybe sensorineural hearing loss, as well as arthritis. Sometimes relapsing polychondritis can be pretty refractory, and in that case, we suspect VEXAS syndrome. Sometimes we see patients with hematologic disorders and inflammatory features, refractory anemias, cytopenias. Here's where VEXAS syndrome may come to mind. Also, in the polymyalgia rheumatica patient, and this is pretty common, that just cannot get down off of their steroids, are requiring higher than usual doses of glucocorticoids. If you have a PMR patient that's requiring 40 milligrams a day, I think it would be good to reconsider the diagnosis because PMR typically is very responsive to lower doses of prednisone. Fever, fatigue, weight loss, hematologic abnormalities, including myelodysplastic features, refractory anemias, and so forth, relapsing polychondritis, vasculitic features, rashes, even pulmonary infiltrates can be components of VEXAS syndrome. The pathogenesis, again, very complex, but somatic mutations in this gene, UBA1, seems to disrupt both inflammatory mechanisms and hemopoietic mechanisms, leading to vacuolization in the bone marrow, as well as inflammatory features. So clinical suspicion is key. PMR, relapsing polychondritis, plus or minus myelodysplasia. There are next-gen sequencing tests for UBA1. Our hematologists are able to do that at our institution, but oftentimes these are send-out labs. A bone marrow biopsy from the hematologist for workup of MDS often yields this genetic mutation as well as features of vacuolization in the bone marrow. A recent treatment guideline was published by the American College of Rheumatology, but it remains fairly nonspecific. Tricorticosteroids, maybe even JAK inhibitors like tofacitinib. For the non-MDS patient, azatidine is pretty effective. Curative treatments include allogeneic stem cell transplantation. Of course, also have to be considered because of its potential for morbidity. Finally, something called Yao syndrome, something brand new on the landscape. This is another gene that is involved, known as NOD2. Now, to the gastroenterologists in the audience, NOD2 is actually very familiar because Crohn's disease is often associated with certain mutations in NOD2. There's another autoinflammatory syndrome known as Blau syndrome that is a NOD2 associated disease. Well, a certain number of mutations have been described to produce another distinct clinical syndrome. And I bring this up because in our practice in autoinflammatory disease, this is racing to the front and is turning out to be pretty prevalent among this group of rare diseases. So just for your awareness, you may see this come up in vocabulary in some of your consultations. And the real hallmark of Yao syndrome, in addition to recurrent fever, is skin. And it can be extremely variable. Most often, we see this deeply erythematous, very inflammatory skin presentation that, to my reckoning, looks like it's been scorched. The only other syndrome that resembles it, in my mind, is dermatomyositis, where it looks like the patient has been sitting under a heat lamp for much too long. The skin is red, it's hot, it's dry, it's got a little scale. It might look like very bad eczema, but eczema is usually not that extensive. It covers the face, tends to be very photosensitive, and very itchy. Yao syndrome is very similar. So skin is a hallmark, and if you have somebody with a very unusual refractory skin condition, in addition to fever, in addition to other inflammatory features, maybe consider this syndrome. There is genetic testing available. Sicca symptoms, mouth ulcers, again, may be reminiscent of systemic autoimmune diseases, may be present. These are some diagrams from a recently published series, in addition to our own series of 24 patients with Yao syndrome. And this mutation here is the most common. No quizzes afterward, don't worry, but you'll see this come up. NOD2 variants, again, leading to dysregulation of the immune system, hyperactivation of this common inflammasome-mediated pathway, production of interleukin-1, interleukin-18. and different genotypes may be associated with different cytokine profiles. So the clinical suspicion for these syndromes and genetic testing for NOD2 variants will support the diagnosis. And again, there are no FDA-approved therapies for Yao syndrome. We often resort to glucocorticoids, DMARDs, and IL-1 inhibition. So in summary, these are a evolving, esoteric, but very interesting group of diseases, the autoinflammatory diseases. They are due to disturbances in the innate immune system. The switches to turn on inflammation are loose for genetic reasons, and you open the window, a gust of wind comes in, and it turns on. There are varied immune and inflammatory manifestations and multiple pathogenic mechanisms ranging from single gene mutations to other mutations in various genes. The diagnosis is made through clinical suspicion and genetic testing, and therapy is evolving. We should always beware of amyloidosis. So I'd like to thank you for the opportunity to present this information to you and to the organizers of the Richie Wernick Memorial Lecture. I've really enjoyed my time spending a little time with faculty, the fellowship in medicine. You know, we are on a long road, but collectively, I think we're making some headway. I'm open to questions. Thank you very much.
Oh, thank you so much, Dr. Wang, for this truly fascinating work. We'll take a look. I'm finding some questions here in the room.
Thank you so much for a super interesting talk about something that I knew nothing about. I am interested from a general internist perspective. How many new mutations are causing this versus how much can we lean on the ethnicity where people are coming from? And also, if somebody has a diagnosis, for example, I know someone with a PFABA diagnosis, what kind of concerns do we need to have about their children?
Right.
Thank you.
Thank you. Yes, these are excellent questions regarding diagnosis, as well as genetic testing versus relying clinically on ethnicity. I'll address the ethnicity question first. For sure, there are a number of very, very well-known mutations that are concentrated in certain races, ethnicities, and parts of the world. FMF is really a prime example, but you may also call upon Central Asia for Behçet syndrome and so forth. All of these do have a smattering of global prevalence. So it's not that you have to come from those regions or have ancestry from that area. And really, it's a challenge. I sympathize and I realize that this condition or these conditions are evolving all the time. It's not infrequent that we send them for genetic testing and they come back with mutations, and the geneticist will say it's a variant of a known mutation in a gene. We don't know its clinical significance. And just like a radiology report, it'll say clinical correlation required. And so we kind of tuck that away. We use our clinical judgment, may have to move forward with some treatment. And we just catalog this experience. And hopefully with that knowledge, we can actually systematically describe something or prove something. New mutations are being described by the month. And if you look at the literature, it's very, very difficult to number one, keep up, and number two, really make some clinical application to a lot of these findings. So it's going to take a while until this comes into sharper focus. I hope that answers your question. Okay.
Thanks. And just to follow up on that, any comments for children or descendants of people with the known mutation?
Right. I personally think it would be reassuring or helpful in patients with definite disease to have genetic testing performed on children and relatives. In fact, our genetics colleagues really advocate getting the histories of as many family members as possible and really assembling a pedigree, both to know what the disease is about, but also to help subsequent generations. Although there is no preventive measure that we have, sometimes it's still useful to know in case there are suspicious manifestations that crop up. Maybe early intervention could be helpful in that case.
Thank you so much. So we are in Oregon, and we have many, many patients who feel like they have an inflammatory condition.
Mm-hmm.
And so some of the examples you gave are quite dramatic, but are there maybe other genes or even just external triggers of some low-level inflammatory response that might help us to understand some of our patients' concerns?
Sure.
And then the connection with diabetes makes me wonder, about this, these anti-inflammatory diets.
Right. Yes, I share your concern. It's a Florida problem as well. Yeah, I feel like I have inflammation, or my stomach is inflamed, or I've had fever, and although it's written down in their log, you've never been able to see it or pinpoint it. And you've already done a bunch of testing for infections and autoimmune disease, and nothing is showing up. At what point do you pull the trigger and say, okay, I'm dealing with something rare but real, and do I go down this road? Very, very difficult clinical question to know. Gosh, I really, but to answer your question, yes, there are a variety of manifestations, and you can get patients who have smoldering, low level, not dramatic presentations. And it really is clinical judgment whether you send them on for more detailed testing. It probably would be helpful to ask or ascertain as much as possible whether this is happening in the family, whether you've got relatives that are involved, where does your family come from, and so forth. Sorry, and I'm missing the next. Oh, anti-inflammatory diets. Yeah. Well, I get this all, I'm sure you do too, ask this all the time. And I'm not dismissing it. In fact, anti-inflammatory diets have come into the rheumatoid arthritis treatment guideline this year. So there is data, and it is important. But I've never seen anybody eat their way out of a RA flare. I've seen patients who have maintained good health and are able to remain in remission, maybe thanks in part to an anti-inflammatory diet. But there are situations where, I don't think as a fire extinguisher, more turmeric is gonna help. Maybe in maintaining health. I don't doubt that, but not in the acute setting.
All right, in our last 2 minutes, one last question.
Oh, thank you very much for a really interesting talk. And as I think back upon my patients, I think about this lady who I think had relapsing polychondritis, but the question is similar to the last question in terms of the spectrum of presentation of these diseases and how you would and you said it's clinical judgment to send them on to special diagnostics, but I just a little more on the spectrum of these diseases, because I doubt I'll ever see a Yao or a Vexus.
Right. Well, a lot of these conditions do have a broad spectrum of presentation. Relapsing polychondritis is usually pretty dramatic. It's usually pretty obvious. the differential diagnosis is, leprosy, but doubt we'll see that too much of that. But there are mild cases of relapsing polychondritis. Really what triggers consideration of other diagnoses in my mind is the refractoriness of patients. Those who respond to maybe requiring higher doses of glucocorticoid, but then don't taper off or cannot taper off very well. We see this quite a bit in polymyalgia rheumatica. And now that we have an IL-6 inhibitor for polymyalgia rheumatica that's FDA approved, it's almost a reflex that, oh, if you failed your prednisone taper twice, you get put on this IL-6 inhibitor. Well, I don't know whether that is actually masking an autoinflammatory disease or it's really treating refractory polymyalgia rheumatica. I think in relapsing polychondritis and other syndromes, that might be the case as well. So not only not to let go of your suspicion with milder disease, but also look out for that refractoriness feature. Those patients that seem to just circle and get accumulation of toxicity from their prednisone. At that point, we might have to think about something else, another diagnosis.
Well, thank you, Dr. Wang, so much for your expertise and your enthusiasm to teach. We appreciate it.
Thank you.